Good evening, everyone. Thank you, Professor Kher, for that very kind introduction. And as you pointed out, we are going to be speaking this evening about recent advances in diagnosis management of autosomal dominant polycystic kidney disease. So the first thing to say about autosomal dominant polycystic kidney disease is that it is potentially the commonest genetic kidney disease that we deal with in our clinical practice. It has a very high prevalence comparatively, and believe it or not, it is the fourth leading cause of ESRD worldwide. About half of all individuals with ESRD, with PKD, will develop ESRD by the age of 55. PKD patients have an 80% lifetime risk for developing hypertension and about 60% risk for developing painful kidney complications. Something which is not easily appreciated is that Adpkd is not just a kidney disease, but a systemic disorder. And the most common organ that is involved other than the kidney, which we know well about, is the liver. About 20% of all patients with PKD will develop symptomatic polycystic liver disease if they are females. The risk for developing symptomatic polycystic liver disease is less in males, and about 3% of all patients will develop intracranial artery aneurysm rupture. In addition to all of that, PKD also increases the risk for cardiovascular disease, stroke, gastrointestinal problems, and hernias. So when a patient comes to you as a nephrologist with polycystic kidney disease, you have to really be a generalist, because we need to actually anticipate and identify all these other problems and manage them appropriately. So how do we currently diagnose polycystic kidney disease? Diagnosis can be either pre-symptomatic or in individuals who already have symptoms or reason for us to go ahead and look for polycystic kidney disease. So the pre-symptomatic diagnosis of at-risk family members, which means someone who comes from a family which has other individuals with polycystic kidney disease, is currently made by renal ultrasound. And the criteria that we use are the number of cysts, and the number of cysts that are required vary depending on the age of the individual. The advantage with ultrasound is that it is relatively cheap and it is extremely widely available. That doesn't mean that everyone knows how best to describe an ultrasound report of a patient with polycystic kidney disease, and we'll come to that in a moment. We know that CT and MRI are also used for disease exclusion in at-risk potential living-related transplant donors when the cysts are not obvious on ultrasound, because CT and MRI are more sensitive and therefore can pick up cysts which will be missed by ultrasound. Now, moving from diagnosis to management, the current management is based on, as Dr. Kher pointed out, early detection and treatment of hypertension, treatment of other cardiovascular risk factors, treatment of renal complications when they develop, like hemorrhage, infection, pain, etc. We look for extrarenal associations and manage them appropriately. When a person develops reduction in GFR and goes into higher stages of chronic kidney disease, we manage them appropriately. And finally, almost half of all our patients with Adpkd will require renal replacement therapy, and we should discuss Adpkd specific issues with them. Notwithstanding the fact that Adpkd provides opportunities for intervention at multiple stages, which can start from pre-implantation genetic diagnosis and early diagnosis if we have better tools available, especially genetic tools about which we'll talk in a moment. And if early diagnosis is made, then we can actually apply nephroprevention. The genetic diagnosis is helped to some extent that because of the fact that de novo mutations in polycystic kidney disease are very low. So the mutations that we are looking for are already known and present, but as we'll see in a moment, the number of these mutations is extremely high. We also now have tools that can really accurately measure the cyst burden and it is important to measure that burden periodically in all patients with polycystic kidney disease. And if we are able to do that, then actually PKD offers us a large window of opportunity for intervention if PKD specific therapies do become available, as they are starting to now. Later in the course, CKD therapies need to be applied because the later progression is by mechanisms similar to other chronic nephropathies like nephron loss, hyperfiltration, proteinuria, interstitial inflammation, etc. So there are a number of important clinical questions that arise in the area of diagnosis, which really starts from the use of different imaging modalities in the diagnosis to examine whether the current ultrasound-based criteria for diagnosis and disease exclusion, especially when we are evaluating living donors, are they appropriate? What criteria should be used for newer high-resolution ultrasound, and what are its potential barriers? And is there any role for imaging-based diagnosis for PKD in subjects without a family history? So most of us are familiar with these criteria, which were validated by Dr. York-Pei and Dr. Raveen in this paper in 2009 in JASN. And you can see that these are age-specific. Between the ages of 15 and 30, the requirement for, according to these criteria, is having a total of 3 cysts in both kidneys, as is the case in the age groups between 30 and 39, but the sensitivity and specificity changes. Whereas if an individual is greater than 40, to apply these criteria, you need to be able to document 2 or more cysts in each kidney. The sensitivities and specificities are shown in this particular table, and as you can see, the sensitivity is relatively low in the younger age groups in PKD2 cases. It becomes better as the age of the subject to be screened increases. Positive predictive value is very high if you are able to see these cysts in these different age criteria, but you may not be able to see, and therefore the sensitivity is variable in these different age groups. The second important question is that when you are evaluating a donor and you do an ultrasound, don't see a cyst, can you reliably exclude Adpkd in these individuals? And once again, the same criteria by York and Raveen and different age groups shown here, and you can see the negative predictive values. The negative predictive values increase as the age increases, 40 and above. The negative predictive value is almost 100%, but below that, the negative predictive value is not 100%, except in the age group of 30 to 39 if you are looking to exclude PKD1. But in all the other situations, there is a small but definite chance that presence of PKD may be missed if one relies only on ultrasound-based diagnostic criteria to exclude this condition. There are a number of well-known limitations. The first is that it applies only to subjects who are at risk and have a family history. As I pointed out in the previous 2 tables, disease exclusion is not possible in at-risk subjects below the age of 40. And we do know that these criteria have been developed on ultrasound machines which are relatively old now. And now we have new generation ultrasound scanners which are more sensitive and therefore potentially better in picking up smaller cysts. And so these findings may not be generalizable to new generation ultrasound scanners. In fact, in this paper, Dr. Pei and Dr. Raveen go on to say that the utility of ultrasound for disease exclusion may be limited in individuals younger than the age of 30 and have a negative or indeterminate scan. In these individuals, one should repeat ultrasound every 6 to 12 months to detect new cysts. But clearly, you don't have this luxury of repeating after a time if you are evaluating these people as kidney donors, and therefore we may need to go on to do molecular genetic testing, to which we come to now. We do know that there are 2 important polycystic kidney disease genes, PKD1 and PKD2, and they're schematically shown here in this particular cartoon. As you can see, PKD1 is a long gene with 46 exons, whereas PKD2 is relatively smaller with only 15 exons. You can see that there are a number of mutations which have been documented in PKD1 gene. A few are shown here, but there are many more. And we'll come to the significance of that in a moment. We do know that there is a new gene which has been identified called GANAB. So now we have 3 known genes associated with Adpkd. When do we need gene-based diagnosis? As described before, gene-based diagnosis is needed when imaging results are equivocal and when we need a firm diagnosis, such as in the case of living-related donors. So you do need to confirm a negative diagnosis in a young potential donor so that that person doesn't go on to develop PKD after having donated. And sometimes when you identify one cyst, it may not be PKD, but you need to clarify the diagnosis in this situation. The other situation is when you have an individual with a negative family history or unusual disease presentation, such as early onset PKD or very mild PKD despite being really elderly and having some cysts and atypical radiological presentations. Having said all of this, it's important to point out that once therapies become available, as they're starting to now, it will become important to really test young patients to obtain a very clear diagnosis before starting treatment that could delay the progression of kidney disease. Okay. But having said that, it is useful for us to recognize that Adpkd-based gene diagnosis is complex. It is not like ordering serum creatinine or serum biochemistry where you order it in the lab and the lab gives you the value and you act on it. We must keep in mind a number of features. The first point to mention is that Adpkd diagnosis or Adpkd genes are characterized by extreme allelic heterogeneity, which means that there are a number of mutations which can give rise to this phenotype. So it is not like knowing that you have this 1 or 2 or 3 mutations to look for and you will be able to either confirm or exclude a disease. Since the possibilities of the types of mutation and the number of mutation are so large, you will need to actually screen the entire PKD1 and PKD2 gene to reliably make a diagnosis or exclude PKD. The other complication arises because of the nature of PKD1 gene, which is segmentally duplicated. So it gives rise to what are known as PKD1 pseudogenes. Which complicate the genetic diagnostic process. And as a reason for this, we need to do what is known as locus-specific enrichment, and the traditional exon capture methods are really unreliable. I know that most of us don't know these things for routine clinical practice, but the reason I'm describing these is that when you order a test to a lab and when they give you the result back, you need to know how good the lab is. Are they doing all these things which are needed to actually to have an appropriate hygiene for the diagnosis of PKD, so that you can go back to the lab and ask them these questions. The third thing to note is that there are a number of variants which might be identified when you do the entire sequencing of PKD1 and PKD2 gene, and that not all variants have pathogenetic significance. We should be aware that almost every 100 base pair we have a polymorphism or a variation in each of our genes. And just picking up that polymorphism doesn't mean that it is associated with a disease. And so therefore we must evaluate any variation which is found for its pathogenetic significance. Now, it's been recognized in the last 5 years or so, or a bit more, is that many mutations which are non-truncating, which do not reduce the size of the protein, these changes are hypomorphic. So the meaning of the word hypomorphic is that they produce not as extreme a phenotype as the typical Adpkd is. And identification of these hypomorphic alleles is difficult. So therefore, unless all these points are addressed in the report, they may be uninformative and difficult to understand and cost a lot of money. And so therefore, we should be very careful ordering these tests, even when the patients insist on knowing them. This cartoon is not meant to be read in detail, but simply to describe and illustrate to you the high level of allelic heterogeneity in PKD1 gene. So there are a very, very large number of variants which are present, and we must look for all of them. So moving on from diagnosis, we can use genetic approaches even to prognosticate autosomal dominant polycystic kidney disease. So this data can provide information about disease severity, and the first thing to know, which is well known, is that truncating PKD1 mutations, which means mutations that reduce the size of the protein, are associated with more severe disease. We also know that PKD2 mutations are associated with relatively milder disease. And as I said a moment ago, there are hypomorphic PKD1 mutations which are associated with milder disease as well. How does this information help? It helps by planning for ESRD. You will be able to tell a patient if the mutation that we find are hypomorphic, that person may, there's a good possibility that that person may never develop ESKD or will develop ESKD very late in life, right? We are also able to select patients for clinical trials. For example, if you're looking to do a clinical trial for a therapy which reduces the progression of Adpkd, you will want to select patients who are at high risk of progression, and therefore to enrich your clinical trial population by excluding patients who have a less severe course will be desirable. And similarly, you also want to select patients for potentially toxic treatments only if they are at high risk of progression of the disease. It may be, again, important for us to know that the way Adpkd diagnosis is now being described includes the gene descriptor, and the gene designation is shown in the left column. So we have Adpkd, Adpkd1T, which means truncating mutations, and in these patients the PKD presentation is severe. The risk of ESRD is very high. Almost all of them will develop ESRD by the age of 50-55. Adpkd1 non-truncating or NT are likely to have relatively mild disease, and if they develop ESRD, it will be later in life. And then some of them will be lucky enough to have this ultra low penetrance Adpkd1 allele, when the PKD is phenotype is really very mild, and they will never develop ESRD. We do know Adpkd2 will have mild disease and low risk of developing ESRD, and Adpkd due to GANAB mutation will also have very mild disease, and they don't develop ESRD. There is a whole bunch of genes which give rise to autosomal dominant polycystic liver disease, and they are shown here. They do have polycystic kidney disease in some cases, but if it is present, it will be very mild, and they never develop ESRD. The other thing to know is the biallelic form of PKD1, which means that these patients have two different PKD1 alleles, which means two different mutations on the two copies of the genes that we all carry. And these individuals have an extreme phenotype. They will have severe PKD and very high risk of developing ESRD. We'll talk in a moment about the very early onset or VEO Adpkd. But before we do that, let's just remind ourselves of the fact that even though PKD continues to progress from very early in life, when the kidneys are phenotypically normal, and as they progress to the age of 40-50, the number of cysts and the size of cysts increases, leading to increase in size of the kidneys. But as we know as nephrologists, that the kidney function remains normal till very late in disease, and if we depend only on serum creatinine for measuring disease progression, we would have missed large window of opportunity. We also do know that throughout this entire life course of patients with polycystic kidney disease, they continue to be at risk of developing these various complications like hematuria, infection, hypertension, etc. And they are at risk of dying even before developing kidney failure of cardiovascular disease, etc. So the point of describing this is that as we order imaging for our patients with polycystic kidney disease, the first imaging, if you have a new patient with autosomal dominant polycystic kidney disease, and if they have not yet developed significant reduction in GFR, the first imaging should preferably include CT and MRI. And you must ask your radiologist to include a maximum length of the kidney, width of the kidney, and depth of the kidney, because these are the parameters which are required to calculate total kidney volume, which is very important in monitoring progression of the disease. As of now, since effective therapies are not really available to a large people, repeated measurements are not needed if the individual is asymptomatic. However, as we'll describe in a moment, that situation is starting to change, and it is possible that we may need to repeat imaging every year to monitor progression of the disease. But I would like to reiterate to all of you that we must ask our ultrasonologist and our imaging person who does CT MRI to report all of these findings so that you are able to calculate total kidney volume. You should also know, to the extent possible, the number of cysts and the size of the largest cyst. The other new change which has taken place is this Mayo Classification, which is based on height-adjusted total kidney volume, and that classifies patients with Adpkd into class 1A to 1E. And the way it is done is that you have this graph on x-axis you have the patient age, and on y-axis you have the height-adjusted total kidney volume. If a person, you can actually take the height-adjusted patient kidney volume and plot it against the age, and you will find yourself in a particular shading area, which will tell you about the class of the disease. So the reason we classify it according to patient age is that if you have any given height-adjusted total kidney volume, say for example 2000 milliliters per meter, and if the age of the patient is 50, then the patient falls in class 1D. But if the same patient is 75 years old, then that person will be in class 1A. And if the same person is 25 years old, that person will be in class 1E here. So it's been shown through prospective studies is that these different classes predict different rates of increase in total kidney volume, different rates of decline in GFR, and different risks of development of ESRD over say the next 10 years or so, and the rates are shown here. So you can actually go and do these calculations online using this tool shown here at the bottom of the screen. You can go online, put in the required data, which is the total kidney volume, age, etc., and you will get the Mayo class. The other concept I introduced a moment ago is the concept of Adpkd very early onset. The very early onset Adpkd is diagnosed when the diagnosis is either made in utero by a fetal ultrasound, which will typically show either oligohydramnios along with hyperechoic enlarged kidneys. And the definition of that is greater than 2 standard deviations of normal for gestational age. Or if the diagnosis is made between birth and the age of 18 months, and you need to have one of these criteria: enlarged palpable kidneys plus either high blood pressure according to age and GFR less than 90, or overt proteinuria. If the diagnosis is made after the age of 18 but before the age of 15 years, this condition is called early onset Adpkd, and again, enlarged palpable kidneys with hypertension, low GFR, and proteinuria are what are required. Now, as Dr. Kher pointed out, the thing that we know we should do for certain is manage hypertension in autosomal dominant polycystic kidney disease. And the point to be made here is that in contrast to the normal renal vasculature, which looks like this, in Adpkd you have renal vasculature which is highly distorted by the presence of the cysts, and most of our patients with Adpkd will have renal-dependent hypertension. So there are a number of really not, I shouldn't say controversies, but questions to which we would like to know the answer. Should high BP be detected and treated earlier in Adpkd, and how should it be managed? Should RAS blockade be the first line of treatment, and so on and so forth? So let's go with the data that we have. We have a fair amount of data, and the first thing to say is that this paper, which was published a few years ago from UK, showed that as the intensity of management of polycystic kidney disease has increased over a period of about 20 years or so, between 1991 and 2008, the prognosis of polycystic kidney disease patients has improved, which is shown in this particular table from the same paper. It shows that individuals who receive greater number of antihypertensive drugs actually have better prognosis, and individuals who receive renin-angiotensin system blocking agents have a better prognosis, and so on. So increasing coverage and intensity of antihypertensive therapy is associated with decreasing mortality in patients with Adpkd. So the next question is always what should be the first line antihypertensive medication? There are a number of slides, but they all make the same point, which is now reasonably well known, so I'll go over it relatively fast, that the first line of treatment should be one of the drugs which blocks angiotensin pathway. So one of the angiotensin converting enzyme inhibitors or angiotensin receptor blockers. There are a number of studies which have compared ACE inhibitors, ARBs, with different other classes, like diuretics here, like with beta blockers here, looking at different endpoints, which is GFR, left ventricular mass index, development of ESRD, change in creatinine clearance or GFR from baseline, and all of them show that beta blockers or angiotensin receptor blockers are better. This is a paper which appeared almost 15 years ago from Dr. Bob Schreier, which looked at LV mass index, which is, as I said right in the beginning, one of the important non-renal manifestations in Adpkd, and that use of angiotensin receptor blocking agent and lower BP targets are associated with better left ventricular mass index. 2014 showed this paper, or saw the appearance of this paper in New England Journal of Medicine, which looked at the measurement of total kidney volume, which was thought of as a surrogate for progression of polycystic kidney disease, and they compared low blood pressure with standard blood pressure, and showed that lower blood pressure, attainment of lower blood pressure targets were associated with slower production or slower progression of increase in total kidney volume. But in this study, they were not able to show significant change in eGFR over time. Okay, and this forest plot is a subgroup analysis of change in total kidney volume, and they really were able to show that the best results are in individuals who have a relatively preserved kidney function and those who are relatively larger kidneys. So this is a summary of the same finding. The combination of lisinopril and telmisartan did not significantly alter the rate of increase, but rigorous blood pressure control was also associated with slower increase in total kidney volume and a greater decline in the left ventricular mass index and a greater reduction in urinary albumin excretion. So based on all of these findings, the current recommendation is to target a BP goal of less than 120/80, and we should use ACE inhibitors so far as possible. If you are dealing with children, because they have a greater lifetime hazard of developing complications, it's suggested that we should start ACE inhibitor treatment even when the children are not overtly hypertensive, because it will prevent the development of left ventricular mass index increase and deterioration in kidney function. So now we come to the most exciting developments that have been taking place recently, Adpkd specific therapies. So the first Adpkd specific therapy to talk about is water intake. And we must discuss this with all our patients because it is the cheapest form of therapy. The recommendation for water intake in individuals with PKD can be divided based on their GFR status. If the GFR is less than 30, then obviously you do not recommend increase water intake, and none of these points are applicable. If they have GFR at the time of presentation of greater than 60, then we should encourage enough. You will ask the question, how much water should we give? So it should be enough to achieve a urinary osmolarity of 250 milliosmoles per kg, and usually it takes about 2.5 to 4 liters per day. Water intake should be round the clock, so patients should be instructed to drink water even at night. The risk is really in this group of individuals is minimal, and the benefit is likely reduction in the rate of cyst growth by we do know that it suppresses the secretion of arginine, vasopressin, and cyclic AMP, which has effect on tubular cell proliferation and fluid secretion, leading to reduced rate of growth of the cyst. What should you do once you have started prescription? We should recheck serum sodium within 1 to 3 weeks to make sure that patients do not develop hyponatremia, and the serum sodium testing should be more frequent if the patients are on drugs which may enhance arginine vasopressin secretion or its effect. Patients who are, because of some reason, on severe protein restriction or severe sodium restriction should be excluded, as should be patients who are volume contracted or have reduced effective intravascular volume due to any reason, those who are on diuretics or those drugs that enhance release of vasopressin, and those who have abnormal voiding mechanisms, because increasing water intake will lead to increase in urinary volume, and they should be able to void normally. The risk is somewhat increased if the GFR is less than 60, but the benefits are all the same, and all the other exclusions, follow-up, etc., remain more or less the same as in individuals with greater than 60 mils GFR. How does water intake help? It helps by reducing urinary sodium, and urinary sodium is associated with larger total kidney volume, as is shown in this particular paper, which looked at a number of disease progression factors as measured by total kidney volume, and one of the parameters which is shown here is urinary sodium, in addition to a number of other things. So let's come to the drug that everyone wants to know about, which is tolvaptan. And so the utility of tolvaptan in management of patients with PKD was shown in this Tempo 3-4 trial in New England Journal of Medicine in 2012. It's important to go over this chart that shows how patients were actually randomized and what happened to these individuals. So they assessed more than 2,100 subjects for eligibility, and a number of them were excluded because they did not meet the inclusion criteria. Of the 1,445 who underwent randomization, 961 were assigned to receive tolvaptan. Let's look at these individuals, what happened. So during the course of the trial, about 221 out of 961 discontinued the study, and a majority of them, which is about 15.4% of the entire group, had adverse effects. So it is important for us to recognize that tolvaptan is associated with adverse events, and we must look for adverse events even after we have started tolvaptan. All right. So that was the point of actually showing you this particular slide. The summary of that particular study was that subjects who received tolvaptan experiences smaller changes in total kidney volume, even though the change in kidney function was significantly different between the two, and the treatment effect for kidney function was significantly different in the two groups. The change in total kidney volume was clearly better in those who received tolvaptan in all the subgroups, whereas the effect on kidney function was not necessarily statistically significantly better in tolvaptan treated subjects in all the subgroups, but overall it was better. So based on the results of this study, a number of regulatory agencies, such as the European Medicines Agencies, the Canadian Drug Regulatory Authority, the Japanese authorities approved tolvaptan for autosomal dominant polycystic kidney disease, and a number of professional societies came up with guidelines for tolvaptan use in patients with polycystic kidney disease. So I'm showing you here the UK Renal Association Working Group recommendation for use of tolvaptan. So according to them, once Adpkd diagnosis has been confirmed and the patient is in stage 2 to 3 CKD and age greater than 18 years, we should be able to document one of the two things, either declining GFR or increasing size of the kidneys. And declining GFR is defined by the decline in GFR greater than 2.5 ml per minute per year, or greater than 5 ml per minute over 12 months itself. The first criteria should be actually documented at 5 points over 5 years. So that takes longer, but if the decline is really fast, you can actually identify a patient to go on treatment within 1 year as well. The other evidence, other bit of evidence could be increase in total kidney volume greater than 5%. We should have 3 measurements over 2 to 3 years, and if one of these two criteria are met, then these patients are eligible for treatment. If you don't have any of these two, then you do a risk prediction, and you can do that by either doing an MRCT, measuring total kidney volume, and looking at Mayo Class 1 or Mayo Class class. If the patient is in Mayo Class 1A, 1B, and total kidney volume is less than 750, there is no indication for treatment, and we should repeat MR every 3 to 5 years, MR or CT. But if the individual is in Class 1C or E, or total kidney volume is greater than 750, the patient is eligible for treatment. If you don't have MR or CT, go for ultrasound. If the kidney length is greater than 16, you should do a total kidney volume, and again decide on the basis of this algorithm. If the total kidney length is less than 16, no indication for treatment. Repeat ultrasound every 2 to 3 years. If ultrasound is also not available, you can do a clinical assessment by calculating the pro-PKD score. If the pro-PKD score is less than 6, again, no indication for treatment. If the pro-PKD score is greater than 6, subject is eligible for treatment. So now let's come to this study, the Reprice trial, about which Dr. Kher mentioned, and this trial was published in New England Journal of Medicine just earlier this month. So let's look at the inclusion criteria of a Reprice trial. And it is worthwhile to mention here that the US FDA had not given approval for tolvaptan use in polycystic kidney disease on the basis of Tempo 3-4 trial, saying that the results need to be replicated, and also that the rate of side effects are high. So in Reprice trial, they included subjects with relatively lower GFR. So 18 to 55 GFR 25 to 65, 56 to 65 GFR 25 to 44, and patients in older groups also had to have historical evidence of decline in estimated GFR of more than 2 per year. And once again, this flow chart shows you that number of subjects entered the study. And important to point out here is a difference in the way patients were recruited into the study. And in that, they had what is known as a run-in phase. So in run-in phase, all the subjects received tolvaptan, and they were assessed for their eligibility to tolerate tolvaptan, because over time it has become apparent that some patients are just not able to tolerate tolvaptan, and so therefore it was not a good idea to include those subjects in the trial, which can be done by including this run-in phase, in which the patients are given the study drug, and if they are not able to tolerate the drug, they are excluded at that particular point of time as run-in failure subjects, rather than after enrollment, because if you or after randomization, because if you exclude patients after randomization, you have lower number of outcome, and it reduces the power of the study. So out of more than 1,490 subjects who received tolvaptan, please note that 126 had tolvaptan run-in failure, and again, the largest cause for run-in failure was the withdrawal of tolvaptan, because they could not take the drug because of side effects. Even after this run-in phase, you can see that more than 680 who were assigned to receive tolvaptan, still 105 of these discontinued because 34 had unacceptable side effects. So the side effect side effect for tolvaptan is real, and the reason for repeatedly mentioning this is that if we are interested in using this drug, we should be aware of these side effects, and we should know what to do to these subjects. The summary finding of this study is that tolvaptan was able to produce a favorable effect in the change of GFR. You can see this is a forest plot showing the subgroup analysis of all patients on top and different subgroups according to age, sex, race, baseline GFR, and chronic kidney disease stage, and geographic region, US or otherwise. This particular chart also shows one of the important side effects, the hepatotoxicity. So they measured SGPT, and you can see that the number of subjects with hepatotoxicity continue to increase over time. So what it means is that it is not that patients are at risk of developing hepatotoxicity only early on in the course of starting tolvaptan. Hepatotoxicity can develop very, very late as well. And so therefore, if you decide to start using tolvaptan, you must monitor SGPT every month in all subjects until you continue to use tolvaptan. Right now, there is no indication to stop monitoring for liver function. And of course, we must also monitor for development of hyponatremia, development of volume deficiency, and so on and so forth. So in addition to the UK Renal Association, the European group also came up with guidelines, and their guidelines are substantially similar in that they do a risk stratification and they take a stepwise fashion. Look at CKD stage. If the CKD stage does not meet these criteria, then you exclude them because they're likely slow progressors. So if the CKD stage criteria are met, then look for evidence of historical GFR decline. Again, similar parameters, greater than 5 ml per minute in 1 year or greater than 2.5 ml per minute per year over a period of 5 years. If that is not there, again, no need to give treatment. If that is present, then the patient should straight away start treatment. But if that data is not available, go to the next stage, look for historical kidney growth by height-adjusted total kidney volume greater than 5% per year by repeated measurements, at least 3 measurements, or use the Mayo equation to predict total kidney volume dependent class and predict the rate for progression, or look for ultrasound kidney length pro-PKD score, as I said before, and then decide for treatment. So basically, we should adopt this algorithmic approach. Now, this particular figure that I'm showing you was the approach that was used by the Reprice trial investigators to start and titrate up the dose of tolvaptan. So they started during the titration phase, the run-in phase, the titration phase, and then this was the run-in phase. So in the titration phase, they started tolvaptan at the dose of 30 in the morning, 15 in the afternoon, then increased it slowly to 45-15, 60-30, or 90-30. And patients who were able to tolerate either 60-30 or 90-30 were continued for further evaluation. If they developed any side effect on 90-30 or 60-30, they underwent a step decrease, so from 90-30 to 60-30 or from 60-30 to 45-15 if needed, and that is the dose that was continued. Those who continue to have side effect on 45-15 were actually taken off the study in this. But the data from Japan shows that many of their patients are not able to tolerate this dose of tolvaptan, and therefore we don't know what is the ideal dose for tolvaptan in our Indian subjects. And so we should be very careful in starting tolvaptan, monitoring for side effects, and if the patients are unable to tolerate, keep the patient on relatively lower doses itself. So having dealt with the most exciting part, let's come to some of the other important but less exciting sections. The vasculopathy of PKD. We do know that patients with PKD are at increased risk of intracranial aneurysms, thoracic aortic dissection, and cervicocephalic artery dissection. The prevalence of unruptured intracranial aneurysm is 2 to 3 times higher in patients with ADPKD patients than in general population. You can see less than 2% in general population and almost 7% in PKD subjects. And the only clinical characteristic which is associated positively with intracranial aneurysm is a family history of intracranial aneurysm. Once again, as shown in this particular slide, that the prevalence goes up from ADPKD subjects who do not have a family history from 6% to almost 16% in those who have a family history. And the practical approach for looking for and managing intracranial artery aneurysm is that if you have subjects with PKD, And if there is either a family history of aneurysm or subarachnoid hemorrhage, do an MRI. If there is no intracranial aneurysm, great. If there is an intracranial aneurysm, we should look for indications for prophylactic repair, and those indications are based on intracranial aneurysm size, location, morphology, patient and general health, and clearly operator experience as well. So the current screening recommendations, as given by Luciano et al. In this paper in NDT, is that we should screen any subject with symptoms which are severe or atypical headache, transient ischemic attacks or cranial palsies, patients in high-risk occupations such as pilots, patients who have a family history, patients who are preparing for some kind of major surgery such as renal transplantation, or who will receive long-term anticoagulation. So even though Luciano recommends this, but frankly we have done a large number of kidney transplants in patients with polycystic kidney disease without screening them for intracranial aneurysms, and I'm not sure that this should be taken as a positive screening recommendation. Patients who really are very anxious regarding aneurysm should be offered screening, and of course patients who have a prior history of rupture should be offered screening as well. So those are the advances that have taken place in the diagnosis and management of polycystic kidney disease in the last few years. There have been a number of other advances also which I have not covered, but they have not reached a level of maturity to be included in clinical discussions or recommendations at this particular point of time, or have failed trials such as use of other growth reducing agents, for example sirolimus, etc. And so for current day clinical practice, these are the points which we thought were relevant. So thank you very much for your attention, and I'm happy to take any questions now.